Thank you, Chairpersons. My compliments to Dr. Sudeep and Dr. Shona for this wonderful concept, which is growing stronger year on year. And a lot of thanks for giving me this opportunity to be here. So the two abstracts, the first one is the Amaros trial, for which the 10-year results have been published online in JCO in end of 2022. So the background basically is de-escalation is the prevalent theme in breast cancer. The reasons are changing disease profile, integration of multimodality management, better understanding of disease biology, and data coming from large research studies. So primary tumor management has been de-escalated for more than 50 years, the axillary management for nearly a quarter of a century. Sentinel lymph node biopsy has become the standard of care, but with sentinel lymph node biopsy came overdiagnosis of axillary involvement in the form of micrometastasis and isolated tumor cells. So since all patients originally were undergoing axillary lymph node dissection after finding any disease in sentinel lymph node biopsy, so it was felt that this may be an overtreatment. Further, a large number of patients with positive sentinel nodes do not have involvement of the non-sentinel nodes. So the question was, can we spare ALND in patients with positive sentinel node and low burden? So this is a prospective study in which multi-center open label CT1, T2 tumors, size was up to 3 centimeters initially and modified to 5 centimeters. Initially, isolated tumor cells were included as positive nodes, but later they were amended and excluded after 2008. Randomization was done at the time of registration, and after sentinel node biopsy, patients were treated as per the randomized arm. ALND was defined as at least level 1 and 2 with minimum of 10 nodes. Axillary artery RT was level 1 to 3 and medial supraclavicular area. The primary endpoint was 5-year axillary recurrence with multiple secondary endpoints including lymphedema and quality of life. Nearly 5,000 patients were registered, of which about 1,500 were treated as per protocol arms. There were crossovers, 37 from ALND to axillary RT and 63 from axillary RT to ALND. So current publication has a median follow-up of 10 years. The axillary recurrence rates are very low, 0.9% in the ALND arm and 1.6% in the RT arm. Total 18 events, and the 10-year cumulative incidences are similar. But interestingly, after 5 years of follow-up, 8 events have occurred. So it shows that the number of axillary recurrence events has not stopped after 5 years of follow-up. The 10-year OS and DFS, again, there is a slight difference between the two arms, but the hazard ratios are crossing 1, so not statistically significant. Lymphedema measured with the circumferences in the mid-arm and forearm showed 44% incidence in the ALND arm and 28% in the radiotherapy arm. Shoulder mobility was similar, and no quality of life differences were identified at 1, 3, and 5 years. Distant metastasis, again 12% and 14.5%. Interestingly, second primary cancers, which this current publication shows that there is a higher rate in the radiotherapy arm, and it is statistically significant at 12.1% versus 8.3% in the lymph node dissection arm. So the author's conclusion is that there is excellent loco-regional control, no difference in OS and DFS. There is a lower lymphedema rate with radiotherapy, and other quality life parameters are similar. So the 10-year results confirm excellent long-term local and regional control and low morbidity after radiotherapy. My discussion basically, one, the trial is underpowered to answer the question of non-inferiority because of the very low event rate in both arms of the study. Lymphedema rates are not based on symptomatic lymphedema and more on just measurement. There is no impairment of quality of life at any time point in the study. The statistically higher incidence of second primary cancers, again something which has not been, sort of the reason cannot be identified, but it is there. Another thing is that many patients in the radiotherapy arm underwent axillary lymph node dissection, and if we see the disease spectrum there, so there was a higher nodal disease burden, N2 and N3, which the table below shows. Nearly 33% of those patients had N2 and N3 disease. So the question today is not only radiotherapy versus ALND. So the options are axillary treatment, no axillary treatment, axillary lymph node dissection, or axillary RT. So the previous trials which have been published have basically compared no axillary treatment versus axillary dissection. Interestingly, all of them suffer from this issue of being underpowered, either because of poor recruitment or low event rate. But overall, the trend has changed significantly, and de-escalation of axillary management is an established pattern in the West. In India, we are gradually moving towards it, but there are differences in disease profile, management approaches, and patient choices also. A majority of Western patient population is screen detected. Again, in India, frozen section is a common practice, and once the notes are positive on frozen section, so ALND is often carried out by the surgeons. So my take-home message is that patients with favorable biology, small primary tumors, clinically negative axilla after axillary ultrasound plus minus FNAC, undergoing BCS followed by whole breast RT and systemic therapy. So if there are micrometastasis or single macrometastasis, we avoid further axillary surgery. If total mastectomy is being done, then micrometastasis, no axillary surgery. If one macrometastasis, axillary RT. If two or more, then axillary lymph node dissection. The second study is basically SBRT for oligometastatic breast cancer. It has been presented in ASCO 2022. So it is a multicentric trial. So basically saying that metastatic breast cancer has a biological spectrum, and in some patients we may be able to modify the natural history by targeting therapy at the metastatic disease. So in this study, 1:1 randomization was done, and 128 patients was the target number. So the trial was activated in 2014 and 129 patients accrued. This is a phase 2 randomized study with 72 events at the time of analysis. So overall, the 24 and 36 months PFS shows very high rates, 45 and 32%, while the original projected was 10.5 months in the control arm and 19 months in the study arm. So basically, the current study does not provide any evidence for change of clinical practice. As of now, what we are doing is patients who have solitary metastasis and long disease-free intervals are being considered for some metastatic directed therapy. Other than that, we have to wait for more results. SABR3 and SABR10 studies are underway, and maybe long-term follow-ups of the current study also may provide some additional information. Thank you.